The tourmaline MM1 study was a study that looked at patients who had relapsed after one or more lines of treatment. These patients were randomized to either the 3-drug oral regimen of ixazomib, lenalidomide, and dexamethasone, or the prevailing standard at that time of lenalidomide and dexamethasone. The study showed a statistically significant improvement in progression-free survival, which was the primary endpoint of the study. It also showed that patients had deeper responses when ixazomib was added to the 2-drug regimen. The toxicity profile of the 3-drug regimen did not seem to be too different compared to the 2-drug regimen. Also, in the tourmaline 1 study, it was found that high-risk cytogenetic patients, even those with 17p deletion, seemed to benefit with the addition of ixazomib to the lenalidomide and dexamethasone. So this FDA-approved regimen is one now that offers a potential convenient oral effective therapy for a lot of our patients. The patient that we are talking about today is an older gentleman who has a performance status of 2. This gentleman is in need of treatment, and what I think is that the regimen of ixazomib, lenalidomide, and dexamethasone is very appropriate for a patient of this nature because of the convenience that the regimen offers the patient. It is a regimen that the patient can take at home. The regimen is well tolerated by older individuals. It is a regimen that also, given his 17p deletion, would, at least based on the tourmaline study, be effective as well as if he did not have high-risk chromosomal features. Ixazomib is a drug that I think is very appropriate for patients who are older and especially those who have limited performance status. The drug, its toxicities are relatively mild, and the drug is well tolerated. So in somewhat frailer patients, one of the things that we often try to balance with efficacy is the lack of toxicity. Ixazomib can cause, in some patients, fatigue, but usually not too marked. It also, in some cases, causes the patients to develop a mild neuropathy or a rash, but those are also, in my own experience, not been a major issue. So in older patients, I think this drug regimen is well tolerated. The use of ixazomib also offers older patients an all-oral regimen in combination with lenalidomide and dexamethasone, and these patients will often have issues coming to the doctor's office, so taking a pill at home once a week together with the lenalidomide and dexamethasone offers them the convenience of home administration of drugs. It is also less disruptive often to their caregivers, and they don't have to take off work to have to bring their loved ones to the doctor's office either. So I think that the 3-drug regimen of ixazomib, lenalidomide, and dexamethasone has advantages that are certainly for a patient who is older and somewhat frailer, go beyond just the patient description and the demographic to extend even to his caregivers and those around him. The patients with multiple myeloma certainly need to have supportive care measures that are instituted for patients. The one thing that patients with myeloma need to be getting is something to preserve their bone strength. So the use of drugs like bisphosphonates or rank ligand inhibitors certainly has been shown to improve the quality of life for patients. Patients who get proteasome inhibitors have got a higher chance of developing zoster infections, so we should be sure about putting patients on antivirals to prevent zoster. For those getting immunomodulatory drugs, especially in combination, we need to be heightened to the possibility of developing deep venous thrombosis. So what we need to do is have these patients on the appropriate strategy to reduce the risk for blood clots In most cases, the use of aspirin is thought to be adequate, but for people who have had prior problems with blood clots or at a higher risk for blood clots than the average patient, full anticoagulation is often necessary.